Right. So I'll be talking about endovascular and hybrid options for complex arch anatomy. And by that, I mean total arch repair. That means we're repairing the entire aortic arch in uh, patients. So this was a field of open surgery as was done in the panel shown in the left, but that evolved to the elephant trunk repair where you see what is shown on the right, and there is this uh, surgical graft that's dangling down into the descending aorta, which is called the elephant trunk. And the results of this were published by Coselli in 2015. You can see there's an operative mortality of about 10%, stroke rate of 7%. So uh, fairly morbid. But this was the gold standard for a long time. And then came the frozen elephant trunk repair, where instead of the elephant trunk, now you have an endograft, which is in the descending aorta, which is an integral part of the whole device, which is a surgical graft in the ascending and then a endograft in the descending. And this also had significant mortality as published by Shrestha and group from Hanover. But more recent results for the frozen elephant trunk showed better outcomes. Mortality is 5%, stroke rate 2.4%. But there is another option. Instead of doing a open repair, you can also debranch the aorta. And there are three kinds of debranching. Type 1 is where the after you debranch, you bypass all the arch branches from the ascending aorta, native ascending aorta. In type 2, the ascending aorta is surgically replaced, and from this, you take the bypasses to the arch branches. And type 3 is basically putting an endograft into the elephant trunk of the repair I showed earlier. So type 1 and 2 are the more commonly used hybrid repairs. Both have significant endo leak rates, about 10 and 12%, and they also have some morbidity and mortality. And the Coselli's group compared open surgery with hybrid repair, and they say there is not much difference in most of the major outcome parameters when you compare open surgery with hybrid repair. So that is the situation where endovascular has come in, and endovascular repair of the arch has a lot of challenges, both anatomical and physiological, which are listed here. And if you were to do a total arch repair, you need to necessarily start the repair from the ascending aorta, which is known as zone 0, and not what we call distal arch repair, where you start in zone 1 or 2. So there are a number of devices being developed for total arch repair. This is a list shown here. We'll very quickly go through them. The TAG Gore endoprosthesis is a single branch device, which is you can have one branch being perfused from the arch endograft. If this is the innominate, then you need to bypass from the right carotid to left carotid and left carotid to the left subclavian. So there's only one branch option here. Then we have the Zenith two-branched two endo-branch devices. This is most popular right now. There are two branches which are inside the arch endograft. So that's why it's called endo branch. And the third branch, the subclavian, will have to be bypassed. So it's a kind of a hybrid. Initially, this had a 17% stroke rates, and more recent reports have shown better results. And they've also come out with a three-branched device, which is not so popular, and the experience with this is much more limited. Cook also has a fenestrated plus scalloped arch device, which is where you can perfuse two arch branches. You could take it, have the scallop for the innominate and the fenestration for the left carotid, and then you would have to bypass from left carotid to left subclavian. So the results with this are reasonably good, but this is not really a total arch because you cannot go ahead of the innominate artery. And you can mainly use this for distal arch anatomies. Then we have the Medtronic's Mona Lisa, which is again a single branch device. So if you were to put that branch into the innominate, then you'd need a couple of bypasses for the left carotid and left subclavian. And Bolton, which is now part of Terumo, has a double-branched custom-made device, which is shown here. And the third branch, the left subclavian, would need a bypass and a plug to close the left subclavian proximally. And that's the bypass and that's the plug. There is a Japanese Inoue branch device. The total arch version would be the option C, which has 3 branches. But this has significant morbidity and procedural complexity, and the stroke rate is 42%, and a very limited experience with this. And there is also the Najuta endograft, also from Japan. Here there are 3 fenestrations for the 3 arch branches, but these fenestrations are really big. They cannot be sealed. There are struts going across them, so you cannot put stents into them. So it only works for distal arch anatomy. So you need a 2 centimeter sealing zone beyond the 3rd fenestration and before the aneurysm. You could also use this for inner curve aneurysm of the arch, but it's not a solution for total arch repair. And then there is the Nexus endospan system, which is very similar. One branch can be perfused, and then you need a couple of bypasses for the left carotid, left subclavian, and you need to plug the origins of these 2 vessels. So these commercial endografts are showing promising results. The designs are consolidating, and stroke remains a significant issue, and you need long-term outcomes to assess their durability. So this is where there is the option of physician-modified fenestrated endografts, which can be custom-made. They can be prepared rapidly. They cost a fraction of what a commercial custom-made device costs, and we find that fenestrations are better than branches in the arch, as I will show in the next few slides. So there are many types of fenestrations. One is in situ fenestration, where you deploy the graft and then fenestrate. Obviously, that's not possible for the carotid and innominate. It's only safe for the left subclavian. Then we have that Najuta's non-sealable fenestrations, which I just showed. Then you have constrained endografts, which have to be manipulated in the arch to get the fenestrations oriented correctly. So that has a risk of embolization and stroke. And then we have non-constrained grafts with sealable fenestrations, which we use. Initially, we had externalized guide wires for this, but now we don't externalize, we loop the guide wires. So this is how we make fenestrations, circular thermal cautery on the graft, and we line the edges with a radiopaque wire, sew it on with 6-O-proline. And this externalization was like this. We make the fenestration and then have a wire going through it, which basically goes from the femoral to the brachial artery. So when the device reaches the arch, this wire is already through the fenestration into the target vessel. We now use this mainly for one fenestration, which is the left subclavian artery. Now we move on to loop fenestrations, and this is how we do it. This is an example, a patient with a type B dissection where the false lumen is aneurysmal. The red line is the plane of the origin of the 3 arch branches. And then we want to view the aorta perpendicular to this in the direction of the yellow arrow. And when we view like that, we'll see panel A, that is the 3 arch branch origins. And we transpose that anatomy onto the endograft, which you see in B. And then we have this imaginary 12 o'clock line, which is marked in red. And on that, we put radiopaque markers, so that tells us where is the 12 o'clock position. And then we resheet, making sure that these markers are up on the surface. And when you look at these markers on the side, they look like straight lines, not like figures of 8. And then another important thing is to resheet without any twist. So when we resheet, we make sure that all the welds of each stent segment are all in a line, as you see with the yellow arrows. And then we bring the radiopaque marker onto the surface, like you see with the red arrow. And so when you're getting into the arch, there are 2 things that have to be accurate. One is rotational orientation, and the other is axial orientation. So for rotational orientation, you just have to make sure that that figure of 8 marker is on the outer curve of the aorta when you are in the working view. I'll tell you what is working view soon. So when you have this on the outer curve and you go up, if it is oriented superiorly, then the 12 o'clock line is also superior and all the fenestrations are also oriented correctly. And for axial orientation, we have this wire from the left carotid to the left femoral. So that we give a little traction on the wire, and if the left carotid fenestration is just ahead of this wire, then all the fenestrations are in the correct axial position. So this is the result in that case. We had two fenestrations stented, and that's the final outcome. We also have a pacing system, which basically involves a sheath in the RV, which stabilizes the pacing catheter, and a buddy wire in the pulmonary artery. And this was published last year. So it's another example of our technique for inner curve saccular aneurysm, showing the same steps which I just described. Uh, Basically transposing the anatomy onto the graft, getting axial and rotational orientation right. And this is yet another example of a large arch aneurysm, which we treated with the same technique. Now, we can also use it for type A dissections where the ascending aorta is already surgically replaced. So in this patient, the ascending aorta is replaced. Rest of the aorta is badly diseased. So we transpose the arch anatomy onto the endograft. And this endograft, so the three fenestrations have small cuffs on them, which basically improve the sealing at the fenestration. And this was published last year of this process of how you make small cuffs. And this was the result in that case. So we have extended the surgical repair with an endovascular repair all the way down to the celiac artery. And in the false lumen, we put a candy plug, which seals off the false lumen from below. So this is the follow-up CT showing the false lumen as thrombosed completely in the thoracic aorta. And we also had to put a plug in the false lumen, which was extending into the left subclavian artery. So basically, we have excluded the false lumen completely, and the true lumen has expanded. We also have a system for cerebral protection in these sort of cases where there's a lot of atheromatous plaque and thrombus in the arch. So this is a case with a shaggy aorta and the arch plus descending aneurysm. And if you look inside, you can see all these protuberant plaques and basically atherothrombus inside the aorta, which is highly likely to embolize. So we have a system where we draw blood from the IVC, send it through a filter, oxygenate it, and then through two pumps, we send it to the two sides of the brain. One is through a left carotid cannula, and one is through a right axillary artery cannula, not right subclavian. And that supplies the right side plus the posterior circulation. This is what the system looks like. And we also have neuromonitoring going on when we do the case. And so this is that shaggy aorta case. We have three balloons completely blocking the three arch vessels. So there is no blood going from the arch to the brain. And then we just deploy the graft, so there is no embolization. In this particular case, just 2-3 tiny bits of embolization, which is a great result considering how much thrombus there was. And that's the follow-up CT. So this was published last year. We have done 31 cases with this technique with very reasonable morbidity and mortality. And most importantly are these performance parameters. The fluoroscoping time was only 89 minutes, contrast volume 192 ml, and the dose area product 495 grays per centimeter square. So total arch endovascular repair is feasible and effective in most arch pathologies, and physician modified fenestrated arch endografts are a economical and rapidly available alternative. Of course, there are limitations, which is inadequate vascular access or very tortuous aorta complex anatomy may not be able to do it. Then there are cost and supply issues. And then there is the availability of the technical expertise to do this. Thank you for your attention.
When will you close the false lumen in type B? Will you close for all patients of type B? Will you do the plug closure, or selected patients? How do you choose that?
Yes, so we don't do it for all cases. We generally do it for patients where at the end of the case, you see a significant flow going up from the true false communication below the endograft. And then these patients usually have a number of intercostals and other vessels which drain the flow away. So there is a continued pressurization of the false lumen from below. And usually we may wait for the first follow-up to decide whether you want to do this or not. But there are cases where immediately you see there's a very significant flow, and these may be patients who are with a threatened rupture, where you don't want to wait and see whether it's going to rupture or not. So you may do it right away in the first sitting itself. But sometimes you can do it electively 6 months later if you find that the false lumen is not thrombosing and in fact enlarged.
So if you think the flow through the retrograde flow, it goes up to the celiac artery, like the lowest part of the stent graft. How much
Yes.
distance will you allow it to go? Means what parameter will you take?
No, usually the blood will flow up, and if it is just the first few centimeters, above the diaphragm, that's okay. But if you see it going all the way up to near the arch, then
Okay.
that's significant. And especially if you don't see significant thrombosis of the first.
Thank you, sir. I think